Shall we start? Everybody ready? Okay. Okay, let's begin the session on the afternoon. Okay, um, this session is the lower face anatomy, and we luckily we have many experienced doctors and world-renowned doctors here to share their extensive knowledge and skills. So
Is it
let's begin
connected
the
to the screen?
first speaker, Dr. Um, Thanonat. Will present us the
Yes,
about a
can
patient.
operate. Yep.
Yeah. Okay.
Yes. So I'm in already, right?
Yes.
You can see or hear my voice. Okay. Okay. Good afternoon, everyone. I'm Dr. Tin Thanonat Kanapurit from Bangkok. So, welcome you all to the afternoon session for live demonstration. Is we'll talk about the lower face and ear injections. What the injector looking for besides the anatomy, besides the rheology, besides the ultrasound image, we're looking for the way we do the physical examination. We call facial measurement. Okay, let's take a look firstly for the chin. What we are looking for, we're looking for the chin width, we're looking for the chin length or elongation. Even lastly, we're looking for the chin projection that we call ricket aligned. Then we will move to the lips. The lips before we do inject the filler. We're looking for the lips thickness. We're looking for the lips eversion or inversion. And even the lips height, the lips width, that we have to consider it or before you do inject for our patient to make that we can get the specific shape that they want. Then for the lower face, we're looking for the vertical height of the face, upper, mid face, and lower face. And we also consider about the fifth horizontal, like the facial width for 5 part. Then we move to the year that is coming, the trendy for 2026 right now, especially in China, in Korea, even in Thailand. What we looking for measurement on the ear? Firstly, we're looking for the ear projection. Here, projection like here, like you pull your patient ear pinna out, we call ear projections. Here, even here, that I point, we call helix. We do the filler injection here to make it thicker. It means their ear look younger. And the last one is the earlobe here, especially in the aging patient. Here have the volume loss, we develop the phylides, that is the law of filler. We have to answer ourselves which part we should focus on, like projection or yellow or pinna. That's all that we will discuss about and show the case this afternoon.
Great. Thank you.
That's
Thank you.
all.
Okay. Thank you. Now we move to Dr. Leonie Helge. Okay.
Almost correct.
Oh, sorry. Helge.
It's horrible.
Sorry. Okay. Okay. Leonie, please. You have 10 minutes to present.
I will talk very quickly. Who is using ultrasound? Please raise all your hands. Pretend if you use ultrasound. Yes, thank you. Everyone is using ultrasound. So I'm going to focus on what he's going to inject. So the lips, the chin, and the ear. And this is my model. And we're first going to look at the chin. And for you who are not using ultrasound, can you freeze the image for me? Oh, hold on, it's not the best. Can you bend over a little bit? Yes, and freeze. Oh, okay. So you know from your anatomy that you have the bone, the mental bellies, and the fat pad. This is the mentalis belly. Here's another one. Here they cross over. And this is the fat pad. And if you look at the image, it's not really clear. If you start doing ultrasound, you're like, oh, I don't understand what's going on. But that is because this is all fibrofatty tissue. And this is the deep fat of the chin, and it's completely white because it's so fibrous. And the funny thing is, if you inject in this fat compartment, so if I do it like this, you see it a little bit better. You see the bone. Can you show them the bone? The black muscle and the white, beautiful white fat compartment in the middle. And this is where you want to inject. You do not want to inject in the muscle. And I use ultrasound to be sure that I'm not in that muscle, but in that white area. And of course, before I start my treatment, I want to know if then there's any artery. We see a lot of vascular occlusions, vascular adverse events of the chin. So I just very quickly make sure. You see, and you see that here she's fine. Of course, you can look for all the arteries. There you see here are arteries. But that's not of your importance. You just want to know very quickly if you're going to inject in the fat pad, is there any artery in my way? And whatever I do, I don't see an artery, so that's fine. We just finished a lip study. The news is that we all inject in the muscle, right? I'm not saying it's wrong, but this is what we do. I'm going to put the probe vertical on her lips. Can you close your... You can eat ultrasound gel, but it's not the nice taste. Can you freeze for me? Okay, we see... Maybe we should put the depth a little bit more. That is more screen filling. Oh, okay. Because it's so in the... Yes. Freeze. Upper lip, lower lip, and this is the orbicularis oris muscle. That was the orbicularis oris muscle. And you can see that it makes a bow. So this is the pars peripherales, and this is the pars marginalis. It makes a hockey stick, remember? So keep this in mind, and now I'm going to place the probe on the lip, part of the lip itself. Can you freeze for me? So she has teeth. These are the labial glands. Now this is the pars peripherales, and this is the hockey stick, the pars marginalis. This is the area that you can inject your filler into. This is the superficial fatty layer. We did a study, it's approximately 1 millimeter to 1.5 millimeter. You will not make it. If you truly look how superficial you have to inject, it's very scary. So what we do, we all inject in the muscle. And if you look with ultrasound, this is what you need to see, 2 black lines. And if hyaluronic acid gets in the muscle, it becomes grayish like that. Because the hyaluronic acid is a little bit crushed, and you see actually the posterior enhancement of the filler. So if somebody comes to dissolve the filler, you have to dissolve it in the muscle. And if you over-inject, you get that stiffness when people are talking, because the muscle is getting a little bit, we think fibrotic, but we're not sure. And if you inject in the right plane, can you freeze for me? So if you inject in the intended plane, the red part of the lip is continuous with the white part of the lip. So if you overfill that correct layer, and you do it again, you have not more projection, it will move here to the white part of the lip. And then from the side, you have that bulging aspect of the lip. So yes, you can fill the lip, you cannot endlessly fill it. How much time do I have?
5 minutes to go.
Oh, so I can start to talk slowly. Okay, so if we look at the ear, actually, it's not in the Netherlands yet, ear injections. The only thing you really need to take care, because here you only have superficial fatty layer. Can you put the color box on? I do the lobe. I mean, I do every now and then the lobe. And what I just do, I check if there's any vascularity in my way, because it's highly vascular. Maybe you need to put up the gain a little bit. No. I'm just check. What I do with ultrasound in these cases, I check if there's anything in my way. The helix has cartilage. Cartilage. So you have a very, very tiny superficial fatty layer. Can you? Oh, okay. Yes, can you freeze? If you really want to be in the subcutaneous area, the black is the cartilage. Okay? So with ultrasound, you can actually see how much room you have. And the room that you have to not inject in the cartilage is 0.7 millimeter. Okay? And if you would go underneath, you have much more space. You have 0.8 milliliter. Okay? So you realize that very often we misinject, right? Okay. And then, of course, you do your injections behind the ear. We have a big artery there. And to be honest, just be practical. The only thing you want to do is to look. I told her ultrasound gel is healthy for her hair. It will grow bigger and larger. Can you put the color box on? So you need to look where you scan. So I don't want to scan here. I'm angulating because, look, and this is what you want to mark. This is an artery. And I'm now on the area where you inject, on the bone. This is all tiny, tiny, right? So maybe you can do the depth a little bit less. The middle of your probe is the middle of the screen. So I go up. I make sure that this area where we have that artery exactly on the periost is in the middle, and I mark it. And this is where I will not place my needle. Okay? And this is how your day is calm and peaceless, and you not end up with a lot of stress. So yes, you need to know ultrasound anatomy, but if you know your anatomy, you're going to place it, you have a quick look, it takes you a couple of seconds, and you can prevent a lot of nasty complications. Okay, thank you.
Okay, thank you. Next session is Dr. Benrita Jidari, the anatomist from Thailand, will show us anatomy on Cadaver live from the hospital. Okay, Dr. Benrita, are you ready?
Yes, I'm ready.
Okay.
Good afternoon once again to our doctors. For the lower face session today, we will talk about the jawline, mandibular angle, chin, lip, and then we will finish with the ear. So first of all, I will talk about the jawline and the mandibular angle. From the surface anatomy, we can easily palpate the angle and the jawline. And can you see here, this is the area of the ankle and the jawline. Medial to the merit fold here, this is the area that correlated with the chin area here. So right now we are going to learn layer by layer dissection. As you see here, this is the first layer that I do dissection. Here, this is the skin layer. The skin layer, as you can see here at the lower face, we can see some subdermal vascular plexus underneath the dermis layer here. So sometimes you do biostimulator injection is have important in this vessel. Right now, we are going to the second layer of the jawline and the ankle area here. This is the subcutaneous fat layer. We have like the superficial lateral fat and middle fat, and you can see some the jaw fat compartment, lower jaw fat compartment here. And medial to the mallet floor, we can see the fat, but the fat in this area have some fiber of the muscle inside the fat because here we have so many lip levator muscle, lip depressor muscle here, and we can see the perforator branch inside the fat here. So next layer that you can see here, I have removed the subcutaneous fat layer. So this layer will be the SMAT layer here. The SMAT at the ankle and the jawline is the platysma muscle here. That's cover the ankle and the jawline here. But at the anterior part or the anterior to the pre-jaw cut, you can see the muscle have attached to the bone by the ligament that we know as the mandibular retaining ligament. So here I would like to show you the ligament. This is the mandibular retaining ligament. So you can easily define by the surface anatomy. If you can see the pre-jaw cut, the anterior to the pre-jaw cut, this is the location of the mandibular retaining ligament. So show you one again here. This is the ligament here. So after that, I will remove the smart layer here. And can you see here, at the anterior border of the masseter, we can see some masseteric lightening ligament around here. That's have the origin from the deep fascia or the parotid masseteric fascia, and then run vertically to the skin and pass through the platysma muscle here. This is the mandibular masseteric lightening ligament. We have the upper masseteric, we have the middle and the lower part, especially at the anterior border of the masseter here. So this is the space here we call the pre-masseteric space. When you get age, this ligament have lengthening. Is it the reason why this space will distension, and then you can get like the sagging of the lateral face, and you can see the prominence of the jaw in patient. So right now we have moved the deep fascia once again. Here this is the parotid masseteric fascia or the deep fascia that cover the masseter muscle. I have reflected this the fascia, and then you can see the deep structure, the most important structure related the ankle. This is the parotid gland here. It's quite big. Some patients have the hypertrophy of the parotid gland, and it also have the accessory parotid gland around here. So in this layer, you also see the transverse facial artery here, and in front of the masseter muscle, you can see in the blue color, this is the ankle, the facial vein and the facial artery together, run together here. So what about the ankle? Here I will show you the ankle. Actually, the ankle of the mandible is the insertion of the masseter muscle. So what happens when you do injection at the bone in this area with high volume of the filler? Sometimes the filler can migrate into the masseter muscle. And can you see once again, I will show you. This is the masseter muscle have the deep inferior tendon in this in below the superficial belly of the masseter muscle here. So once again, please aware that when you do injection at the ankle, you make sure that the filler shouldn't migrate to the masseter. And what happens when you do injection to deep and you have the slip of the cannula behind the mandibular ankle and the mandibular ramus? You can see the vascular here. This is the branch of the external carotid artery. This is the external carotid artery. It's run behind the ramus of the mandible here. Please aware this area too. Don't slip and go too deep to cut, to insert the cannula or the sharp needle to this vessel. So right now, we are moved to the medial part. At the middle face here, the junction between the jawline and the shin area, we have depressor muscle here. You can see the DAO, depressor ankuli oris muscle. And you can see some fiber of the muscle here. This is the depressor labial inferior muscle. The DAO run more superficial when compared to the DLI muscle here. And above, this is the orbicularis oculi muscle. That's a core muscle of the lip here. So, and then now we are moved to the shin area. So at the shin, you can see the skin, you can see the subcutaneous fat, and you can see the fiber of the mentalis muscle here. The mentalis have origin from the incisive fossa and then have the insertion of the skin, and under the shin, under the muscle, you can see the deep shin fat around here. So it's a very thin fat in this area. So this is the overall of the chin. I will show you the vascular later. So right now, we are moved to the lip area. The lip, I will show you first. Normally, our lip have three parts. As you can see here, this is the skin part or the cutaneous part. And we have the wet, we have the dry lip part or the vermilion here. And we also have the white mucosa part. This is the wet lip area. So inside the lip, we have the orbicularis, oculi muscle, and the core muscle or the lip here. What about the vascular? Can you see here? This is the orbicularis oculi muscle. Normally,
oris,
our
right?
vascular run close to the mucosa here. Mucosal
Auricularis.
site here.
Oris, right?
And yes, sorry, orbicularis oris. I just I talk a lot today, so sorry. Okay, this is the orbicularis oris muscle. So here, this is the superior labial artery, and you can see here at the lateral part, it runs in the submucosal site, but close to the midline, you can see the superior labial give rise the branch as the superficial branch of the columellar artery, and then we go to the nose later. So this is the lip area. Similar to the upper lip, you can see the lower lip. The lower lip also have the small branch of the inferior labial artery here. So for the arterial system, I will show you later. Right now, we are moved to the last area. This is the ear. So can you see the ear? At the ear area, if you see from the surface anatomy, we can see the tragus of the ear, antitragus, and we can see the curve of the helix here. Medial to the helix, we can see the antihelix here. The antihelix have a Y shape in the upper part and is divided into the lower class and the upper class. Between the class, we can see triangular fossa. Below the triangular fossa, we can see another fossa that we call simba and then cavum in the lower fossa here. So what about the vascular here? The vascular supply anterior part of the ear come from the superficial temporal artery. This is the branch that we call anterior auricular artery. It have the lower branch, middle branch, and the upper branch. But the most important branch about the ear that Dr. Leonie told us before, this is the posterior auricular artery. Can you see this vascular? This is the posterior auricular artery. It's the branch from the external carotid artery. So this branch runs at the posterior auricular groove between the mastoid process and the ear cartilage. So every time you do injection close to the groove or medial to the mastoid process, please be careful this vessel. This vessel is the brain blood supply of the posterior part of the ear, and it gives the branch penetrate the cartilage and supply the anterior part of the ear at the triangular fossa, and the at the root of the helix is penetrate from the posterior part and then become more anterior in this fossa. So this is the overall of the ear. And finally, I would like to show you about the vascular system at the periorbital area. Here, this is the Schiller, modified Schiller staining that I do. And can you see here? This is the band of the facial artery. Gives up the labiomental artery here, and it also gives the inferior labial artery here, and it gives the superior labial artery. And can you see the superior labial have strong anastomose with the other sides of the superior labial artery. At the lip area, you can see, at the lower lip, you can see the ascending mental artery. That's the main blood supply at the chin area. When we do injection at the chin, we must be careful this branch. And it has strong anastomose together with the labiomental artery and the inferior labial artery. This is the overall vascular system at the perioral area. And finally, zoom out please. I would like to show you. This is the vascular system of the our face. So it means that when you do injection at the lower face, it have the possibility to migrate of the filler into other part of the face. So because we have very strong connection of the face. Thank you so much.
Wow, thank you. That was very clear. Fantastic, Dr. Benrita. Thank you. So we now back to Dr. Thanonat. He present us the live demonstration in live patient injection on the lower face jawline masseter. Okay. Chin.
Hello, I'm in. Okay, let's take a quick look on. I will start with the Masseter injection with botulinum toxins. Firstly, we do it. We identify the boundary of the Masseter. That's always ask the patient to bite, กัดฟันครับ You see, and you use your finger to identify where is the border, upper anterior and posterior and lower border. And why we have to identify? Firstly, here at the anterior border, they have the rhizolis. That's why I always keep at least one finger bait posterior to the border here. There is no go zone because of the toxin is liquid. They can spread very well. Sometimes they can hit or even affect to rhizolis that make our patient cannot smile well. Then I divide in 3 parts. I skip the upper third one. Firstly, in this part, many, especially the Asian patient, don't like here to be sunken, to be hollow. That's, she perceives that will look aging. And secondly, if the patient have the jaw thickness here, if you knock all of Masseter, sometimes the fat here gets more sagging, look more prolapsed. And the last one, if you keep knock down all of the Masseter down, your patient will use the temporalis muscle to shielding. Instead, they will come back and complain, doctor, I even cannot chewing the sticky food. I feel get headache. That's why many times I spare the upper part to do the masticatory function. Okay? Then I start to inject with the toxin. In this case, I spend 30 units for the lower to third here. You will have a question, should we do inject 3 points or the 5 points? The answer is on your patient face. If the area that we want to inject is very large, 3 points is not enough. You have to divide for inject at 5 points. Okay, for this lady, it's not so large, so I will do inject only 3 points. I will start at the most contraction point by asking the patient to bite and find where is the most powerful muscle tone. Got fun. Here, okay, I do start injection here. Inject perpendicularly. Go to the deep layer, ปล่อยเลยครับ relax. Then I do inject at the deep layer and stop injections. Then withdraw and re-inject at the superficial part of Masseter.
And what dilution are you using?
And go to the second one, that is the tone, the muscle tone. That's okay. The next one, กัดฟันครับ Here also have the powerful muscle tone. Okay. ปล่อยครับ Inject with the same way at the deep and go superficial part of the Masseter. And lastly, I will finish the third part of injection as Masseter. Let's find out which is the next station of our do puncture. กัดฟัน You see, I rendering my thumb around to find where is the most contraction right now as the third point here. Okay, I start inject with the 2 layer, deep and superficial heads, so that we can prevent the paradoxical hypertrophy of Masseter. Okay, then with the time left, I should go to the jawline injection with filler. But after I remove, you can see in overall, she have the bigonial width. It's quite wide, make her have a square face. One point that you have to learn, it should not always end up with toxin at Masseter. You have to do the physical examination by yourself, which cause her have a square face. Firstly, the bone. Second one, or it should be muscle, or even the gland, parotid gland hypertrophy, and or the skin that becomes sagging down and accumulate for this layer. That's make her square. So you have to do the physical examination by yourself and find what is the cause for that. If you have your ultrasound, it can be tell you the answer. Okay. Right now we will move to the lower face. Okay. The jawline. Okay. This is the interesting case. If you take a look from the subnasal here down to the menton here กล้องข้างนะครับ Let's take a look on the lateral view. Okay, here subnasal to the menton here. We divide in T part, upper, middle, lower. The upper lips should be 1/3 in height, but and the low from the stomian to the menton area should be 2/3 in height. But in this case, the lower part here from the stomian to the menton is very short. What's telling us about these clinical findings? You have any idea for that? Okay. Always, the lower face is not only the mandible, it's related to the teeth of patients. So always ask your patient and see, explore how the teeth condition of her. ยิงฟันเยอะๆ She have the deep bite, you see? You know the deep bite, right? It means the condition that the upper teeth cover, the lower teeth too much, okay? Here, I will show you. Here. You can see it clearly. So in this case, better to work with the dentist to do the dental procedure to improvement. That's what I tell you is we should not just inject on bone toxin like that. We have to consider it all because today is 2026. We have many knowledge. We have many AI to integrate the knowledge for us to get the best clinical result for our patient.
3 minutes.
That's it. You can see for this case. So in this case, the thing that I will do is like a filler to elongate her chin down. Okay. And after that, I will ask her to meet a dentist to fix her dental problem. Okay. And the way we do inject for elongate chin, it will be the inferior border here. And if you want the projection, injection should be here. In this direction, it's different. So you have to think which kind of result that you want first. Okay, here, fix the needle and do aspirate for 5 seconds. No blood inside. Use your finger to control the filler here. 0.2 mil. Then I move laterally at the same level here. Again, always do aspirate like this for 5 seconds and use your finger to confine the filler to make sure that they located at the point that you want. Okay. The last one. Okay, here. You will see it's become elongations, more elongation. And then I will show you how to do the massage for this. Okay, doing like this. The purpose of injection want to elongate the bone in this area. So the way we do injection, we do the bimanual here, like pressing down, use my thumb at the upper and use my index at the lower here. Squeeze it down. You should not just compress. You press and rolling down. Okay, here. Then I will fix the filler, the remind filler sharp needle. Here. If you take a look here, this is her earlobe. It's quite close to the angle. The distance between this way is quite closing. It means somehow she have the short lemma of mandible.
1 minute.
So the way we do inject is not create the projection. Okay, the last one, just show you here. Okay. Same way, hit the bone and do aspiration. Okay, done. Then I will do injection on cutaneous layer along the body of the mandible here. Okay, cannula นะครับ I will move to this side. Okay, เข็มเจาะครับ Just do one bevel, puncture. Okay. My tips of cannula on cutaneous layer right now. Okay, and do aspiration. I will start injection at the linear. Retrograde. You can see the product is filling up along the border of Jawline. Okay, I finished like this. Then, it is important how we do massage because many times, you see, the product become the nodule like this. We have to massage it spread evenly. You see my thumb press down and rolling laterally. Here, if you keep squeezing to make it sharp, when the patient opens the mouth, you can see it's the floating lump. So the way we do massage is very important for, especially for the filler injections. Piat, I'm done already. I will finish other half. Thank you.
ว่าอะไรนะหมดเวลาแล้วนะครับ Time's up.
Then we will move to the
Yes.
lips and chin
Yes, sure.
with Dr. Kampon.
Yes, let's move to Dr. Kampon Sojarantham. He will show us injection on chin and lips. Dr. Kampon.
Hello, good afternoon. My name is Dr. Kampont, and I'm going to share with you that how could we use the cannula to inject the lip, and how could we use the sharp needle inject for the chin. And นั่งตรงๆนิดนึงครับซูมอินเลยครับซูมอิน And in this case, you will see that her chin is a little bit protrude. So we need to increase the anterior projection on her chin. And another thing that when we finish the lip injection and the chin projection, what will happen? The line over here, or what we call is a labiometal crease, is going to be deeper. So that means we need to prepare, or we need to inject at the labiometal crease area after we finish the lip and the chin. And in this case, for the lip, I'm going to use the cannula for the upper lip and the lower lip. And how could we use the cannula? That's something that I would talk about it. That it's about the subcutaneous fat. If you are going to use a cannula, it's meaning you must be able to spread the product into the medial part or the middle part or the lateral part in the subcutaneous layer. If you cannot, what it will happen? And many times it will end up like a sausage, or it's like a worm. So I'm going to show you now how could we use the cannula. ขอ cannula เลยครับ Okay. lay back up. I'm going to use about 5 millimeters away from the oral commissure. And the product that I'm using is the moderate G palm. I use a 25G cannula. And the plane that I select to use is a subdermal layer. Okay. And how could we know that this is in the subdermal layer or in the subcutaneous layer? When you lift up the cannula, you will appreciate a shaft of the cannula. If you cannot appreciate or you cannot see the shaft of a cannula, it means that it's too deep. You might be intramuscular or behind the muscle. And I already marked where I'm going to inject. I touch the midline. I see the tip of my cannula, right, over here. And at this part, I start inject approximate 0.1 cc. And then the second area is in the middle compartment of the subcutaneous layer. It is approximate another 0.1 cc. And at the lateral part, I change the direction because I would like to lift up the corner of the mouth. I'm out and I'm reinsert in this different direction in this way. And I just inject a small amount, approximate 0.3 with linear retrograde. And now you will see that the corner is turned up. Okay, open your mouth a little bit. Then I'm going to inject for the lower lip. Get inside superficially. Until you reach the midline. Lift it up to make sure it's anterior to the muscle. I would inject approximate 0.2 cc. Using linear retrograde. You could appreciate over here that I'm not going in and out too often because that could trauma the lip. Okay, now we finish this size, and if the camera zoom in, you will see the difference between left and right. Now the corner of this side is already turned up. This is still downward. Next step, I'm going to do on another side. If you have any question from the Prasa Atini, you could ask anytime.
You have 3 minutes.
3 minutes. Okay.
And if anyone has any questions in the audience, feel free to submit in the app and we can try and answer them at the end. Do you always use cannula, or is
Okay,
there
back to superficial layer.
a time when you sometimes use needle in the lip?
In my practice, more than 50% I use a shaft needle.
How do you
But this
decide?
year, I would like to show that if I would like to increase or I would like to create a shape of the lip, I prefer to use the cannula. Sorry, the shaft needle. But if I would like just only volumize the lip, I prefer to use the cannula.
And I've seen some injectors sometimes do deep lip injections, like submuscularly. I was wondering if either of you ever do that, or if you ever do that, and if so, why? I don't.
S- โอเคขอเข็มชาร์ปนะครับ Okay, now I'm going to inject her chin to create the round chin and the projection. So I go the midline, use a shaft needle, 20 teeth, like this position. Do the aspiration. Because Dr. Som already showed us that there's a chance of ascending artery. Yes, 0.4 cc. ขอแคนูล่าครับนิดหนึ่ง So the last step, I will fill up the labiomental crest with the moderate G palm. Because for the female, we don't like to let it be so deep. It's different from the men.
Do you ever do subcision of
In
the
the
labial
subcutaneous
mental
layer.
crease?
Sometimes, but in this case, you can see that it's very easy to get inside. So in this case, I do not do the subcision. But some case that is really stiff, you cannot pass your cannula, I would do the subcision.
And what tool do you use for subcision? Do you use the cannula or like a no-core needle?
I use a cannula.
Okay, it's thumbs up, Dr. Kampot. Please
Okay,
wrap up.
I finished. So in this case, I use the cannula technique to for her lip, and totally I use a 1 cc for her lip, and approximate a 0.4 cc for her chin, and approximate 0.5 for the labiomental crease. Thank you.
Thank you. Yes, and we move to the next speaker, Dr. Wally, who showed us the live injection on patient on the ear. Okay, Dr. Wally. Now, do you have any comment?
Hello. Yes,
okay.
good afternoon.
Yeah.
Oh, Leonie's there. Okay, today's my topic is prominent ear. It's not lower face, right? But it's I think it's a new thing. I think it's first time for the IMCAS, right? And a lot of Chinese papers is published because Chinese doctors doing this a lot of time, so that Korean doctors also doing this a lot of time these days, because that the proportion is very important when you do the selfie, right? So the most important for the selfie is that the proportion, not the big face, right? If big face, you just take a picture like a more, it's okay, right? But you know, even my $2 just take a selfie every day, right? So that patients want proportion to be prominent here, so that face can be looks smaller, right? But the most important thing is that, of course, complications. So what I'm doing in my clinic is that to detect artery first and then inject HA fillers. So this is a nice patient, and if you do the Doppler ultrasound at the posterior auricular area, you can see the nice artery, which is posterior arteries. Posterior auricular artery. Can you see that at the stage?
No, we can't. If we could get the
Yes.
ultrasound
So
up on the screen.
Can you? Can you see that? Oh my God! Can you see that at the hotel?
No,
No.
we
At the
can't.
conference room?
Now we can.
No, no. Now, yes. So one of the most important thing is that the lower part is the posterior artery is sometimes it's very prominent.
Yeah.
So if you want to make a prominent ear, then you should inject HA filler like more than 2.5 cc or 3 cc's. Even like the Chinese paper says like 9 cc's or injection here. So what does it mean is that have to inject very much amount. But like this patient has relative small posterior auricular arteries. But if you inject HA filler inside the artery, then there might be a skin necrosis or even blindness case. There is 3 cases of report of blindness case. So one of the most important places is that the lower part, you have to check the posterior auricular artery. And then central part is the most important place. And central part, you can see the perforators. Medial perforators of the posterior auricular artery. So if you inject the HA filler in there by needle, then you might have a problem, right? So you know, the layer is very thin, so it is important to not to inject the filler in that area. And superior area, you can see the superior auricular artery. Okay, in her case, it is okay. Yes. So I think it's a superior auricular artery. She doesn't have a medial. She doesn't. Yes, there might be a big artery there. So the entry point should be not very top of the ear, just to be behind the artery. Yes, that is very big artery, which is running for the superior auricular artery. So one of the most important thing is that the external carotid arteries runs to superficial temporal arteries, and the posterior auricular arteries. Posterior auricular arteries sometimes is very big. She has a relatively small posterior auricular artery. She has central perforators, and she has a superior auricular arteries. So superior auricular arteries, check the superior auricular artery, and then you make an entry point just beneath the superior auricular artery. So now we're gonna do the live injections. So can you put the yes, and if you have any questions, then just tell me now.
Given the
During my
high-risk
preparations.
nature of injecting behind the ear, would you advocate for only injecting in that area if you have ultrasound?
I cannot hear anything here. Sorry, but what was the question?
Given the high
I cannot hear
Oh.
it.
Okay.
Okay.
Given the high risk, nature of injecting behind the ear and given the intricate vasculature back there, would you advocate for only injecting that area if you use ultrasound?
모르는 거야?
Leonie, would you say yes?
It's not working.
Yes.
Oh, yeah.
Yes,
Oh,
yes.
that's nice. We said it together.
Always. That's the reason I'm standing here right now, because that there are so many papers and so many procedures not doing a ultrasound. Maybe in Korea, relatively expensive, but not many people are doing it. Just to inject it, and by needle, a lot of doctors. Because if you inject a needle, the projection is relatively easier. By the cannula, it is very difficult. But have to detect artery first. That's very, very important. Even, we studied a lot of facial arteries, right? Facial arteries running, blah, 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 supratrochlear, supra. But the posterior auricular area, they're so dangerous. Same as like facial arteries. So that's why we have to do it if you are injecting posterior auricular area. And the second thing that's very important is that should be very aseptic. It's because it's very near to the hair area, so should be very, very aseptic, but it's relatively okay, lidocaine. And as you see at the superior auricular artery is running here, so we make an entry point just a little lower pain. Little bit pain, okay. And we make a lidocaine. And also we have to make a lidocaine to the circus because we're gonna inject here also. And, okay. And the posterior auricular artery should not be injected. And for the central perforator area I will inject very small amount, okay? This is lidocaine, right? So. No, more.
Okay, 1 minute left, Dr. Wally.
So if you have any questions, oh my God. Oh my God. Okay. And puncture. In my clinic, actually, I do the surgical draping, such as plastic surgery. But right now, I will do as much as possible. And then we make a puncture with a 21 gauge and with a 21 cannula, inject. I am injecting Luriang number 6 which is the hardest. When I calculate the G star, then it is the most hardest filler, which can be used for the chin area. But the prominent ear also should be a very hard filler. And also, are you okay? Okay. So posterior area, the perforator was like middle central area. So that's I will inject a little bit majorly, and I'm not going to inject this one posterior auricular arteries.
How many cc's do you use on average per ear?
It depends on how much pace for patient. Usually 2 to 3 cc's for the one right here, one year.
And do you find that this filler in this area lasts longer than filler elsewhere? Like I find, I don't do this injection, but when I inject the ear lobule, I find that it lasts much longer than filler in the lips or in the lower face.
Yes, it's definitely prolonged more than a year, and yes.
Okay, thumbs up, Dr. Wally, please wrap up.
Bethany. Okay,
Yeah.
thank you. So, as I am a plastic surgeon, this area is contaminated, and this area should be not contaminated. And this area is contaminated. This area is contaminated. This area is not contaminated. So, I'm trying my best. Okay. Give me more.
How long have you been doing this injection technique? Like over the past 6 months, has it gained traction or has it been popular for
It's been
longer?
2 years.
Okay. Is it a commonly requested procedure?
And my first time that I saw the paper of China, and patients asked me to do this. I said that's what is wrong with you, or something like that, because it has been a long time that prominent ear is 5% of the population, and it's regarded as the congenital deformity, and we do the operations for making lying ears. But suddenly it became like trends. Even my daughter wants to do that. So like I did 2 years experience, and right now I have a lot of patients. So I injected how much?
Can we zoom in on her face to
1.5
see?
cc. Yes, can you see the face to right side and left side? It's because of the. Can you see the difference? Not very much, because I injected 1.5. Okay.
And you said you're using a high G prime filler, correct?
Yes. G prime, G star. So G prime squared, G double prime squared is then the G star. That means that how hard the HA filler is, and the real number 6 is the hardest filler. So I'm using it.
Have you had any complications since doing this procedure?
No, for me, because I'm preventing vascular compromise. Well, not 100%, but comparing to other doctor, I'm using an ultrasound, so prevention of vascular complications, and I really think about infections. Like, actually, this is the first time I showing my demonstration to other countries of ear injections. But you know, one of the most important thing is aseptic technique, but it's so I didn't have any complication of infections.
Yes, yes. So Dr. Wali, we have to move to Q&A part. Okay.
Yes,
Yes.
yes, yes.
And I have a question for Leonie. For those of us who don't use ultrasound, I think it can seem somewhat intimidating, especially at the beginning. Do you have any like resources or conferences that you would recommend to start learning?
We just had a
Uh,
2-hour session, and then there now, as we're watching,
Yes,
we have a 2-hour session. Yeah, he was there with me this morning.
Yes,
Beyond IMCAS.
yes,
Yes, so every IMCAS, you have the opportunity to do a 2-hour hands-on. And this is what we teach you. Start very practical. Look for the arteries, mark them, and avoid them.
okay.
And then
Two,
as
three,
you do
four.
stuff, we give courses as well, a whole day. But be practical. Where's the artery? Mark it, avoid it.
Have you seen any complications from ear?
Yes, unfortunately, I couldn't attend the pre-congress, and Leonie told me that pre-congress was very hard from the morning to the evening, right? So if you have if the audience has want to practice the ultrasound, then it is right now it's the only solution to register pre-congress of the ultrasound of the INCAS, or just actually right now is doing also at your 6th floor. So
Lots of
I
opportunity.
hope that a lot of people, a lot of doctors use ultrasound.
And then a few questions from the audience. One question, and I think any of the injectors or anyone on stage can answer this. Can we create definition of the vermilion border with a blunt cannula? What do you think?
Yeah, I think it's not as good as a sharp needle, definitely.
Do you
Yes.
primarily use needle for lip injections?
Yes, yes.
I know Leonie and I were talking about that. Both of
Dr.
us also use needle. But I always say in aesthetic dermatology, there's no right or wrong way. But I do personally feel, especially definition of the vermilion border, I tend to use more needle.
You're more likely to be superficial.
Yeah. And that's a very interesting study that you spoke on earlier, how I think this is true with a lot of injection anatomy. We're learning where we used to think we were or not. I know they've done some studies similarly in the temple that shows even the most skilled dermatologists and plastic surgeons who know their anatomy aren't in the plane that they think
Okay,
they
I
are.
don't know if I have time to comment. We don't know our anatomy. Just accept it in the ASG, and then we will put it on our website, cutaneous.com. All deep fat compartments are one layer. So the deep fat compartment, the zygoma, the medial sheath, the temple, the pre-auricular, this is one compartment. And this is because with ultrasound you can look around and see all the connections. And filler spreads in completely different directions, which is no problem, but it prevents you from an overfilled face. If you inject here in the deep fat, what we just saw, you actually fill the superficial fatty layer.
Yes, I see a lot of migration. Yeah, totally agree. That is
Yes.
one layer.
And we're not doing anything wrong, and we can do exactly what we used to do, but you have to know where it goes to.
Yes.
Yeah.
And one question to you, Leonie. Do you think, since the high risk nature of the ear injection, yes, so even we use ultrasound, we cannot see any vascular, any artery. Can we say that we are we safe to do it?
I rather like to see an artery. If I don't see it, I'm like, oh. So control your settings. So go to an area where you see an artery, and then you know that your earlier observation was correct. If you don't see it, yeah.
I think we have time for maybe one more question. Another question from the audience was, do you use the same product for chin and labial mental groove? I can share. So I think it depends on a lot of different factors. Typically for the chin, I use like a higher G prime. I know in the US we have nowhere near the number of filler that you have here. But typically for the labial mental groove, if it's really deep, I sometimes will do a layered approach, sometimes deeper with cannula with a higher G prime product. But then sometimes I find patients who have that superficial crease do need more superficially placed filler with a lighter filler. And I do, similar to the presenter before, sometimes will use my cannula to do some blunt subcision, and then I also always do neuromodulator in the chin to kind of help adjust that as well.
Okay, so
one comment is that I had experiments to gather 41 different kind of HA filler in Korea, and went to the laboratory to do the rheometers. Rheometer is that they are very different from the 0.0 hertz to the 1 hertz. So a lot of company says that our product has high G prime at 0.02 hertz, which is if that filler is going, if it has a frequency of a high, such as high 1 hertz, then it goes down. So it means it's not all the filler is competitive. I mean, it has. I mean, almost all the fillers in the market says that they have a high G prime. So you have to at least
see how it plays.
Do the sample and
yeah.
then see
we don't know our filler and we don't know our anatomy. Yes. Well, thank you. I think that is all the time we have.
So I have to think about it.
Yes. Thank you to our injectors. Thank you to our moderators and Leonie.
okay, so thank you.